Welcome to today's lecture on assessment in music therapy practice and research. Today we'll have a panel discussion between three presenters, that is Professor Wendy Magee, Dr. Eric Waldon, and we'll have Dr. Jonathan Poole, who is our host for today. Although we also invited another presenter, Karen Twyford, who will be having a pre-recorded presentation played. Today's recording we only have Wendy's presentation and Karen's presentation. Eric's presentation was not recorded, unfortunately, but we also have the panel discussion at the end, responding some of the Q&A. Thank you very much. Enjoy.
Hi everyone, my name is Karen Twyford and I'm a music therapist working in Western Australia at the Perth Children's Hospital. I am also a current PhD candidate at the University of Western Australia. I would like to thank Jonathan Poole and Rebecca Atkinson for providing the opportunity to present as part of this panel on music therapy assessment today. In Australia, we make an acknowledgement of country at the beginning of presentations and meetings. I'm joining you today from the Burruли Nation, also known as Perth, a place that is the traditional land of the Whadjuk Noongar people. I apologise that I cannot be here in person, but I'm more than happy to answer any questions that you may have following this presentation. Today, I will be discussing results of a recent scoping review completed as part of my doctoral research. I will provide a brief background and then discuss the methodology and findings of this review. This will include a summary of the general, participant and intervention characteristics identified and look at the types of assessments utilised. I will then consider areas for future research. My research is exploring the impact of music therapy for children and adolescents with an acquired brain injury, or an ABI, across the spectrum of rehabilitation in tertiary hospital settings. It involves 3 studies, and today I am pleased to share the results from the first one, the scoping review. I would like to acknowledge the support of my supervisory team for their expertise and guidance with this research, and also say a big thank you to the expert knowledge users who kindly provided their time and knowledge to this project. This scoping review has now been published, and I will share a link to this at the end of the presentation. As music therapists, we are aware that music can be a useful rehabilitation tool due to the motivational and emotional role it can play in a patient's recovery. Evidence demonstrates the effectiveness of music therapy for functional outcomes within adult neurorehabilitation. However, findings from this research cannot be generalised to a child and adolescent population due to the neurological differences between children and adults. The type and extent of available emerging evidence for paediatric populations is unclear, and for this reason we used scoping review to determine the extent, range and nature of existing evidence for functional outcomes experienced by children and adolescents with a neurodisability who access music therapy as part of neurorehabilitation services across all levels of care. Although the focus of the larger project is acquired brain injury, we chose to source evidence for paediatric neurodisability to ensure breadth and make sure that no sources were missed. We utilised JBI scoping review methodology, the PRISMA extension for scoping review, and the population concept and context, or the PCC framework, to conceptualise our eligibility criteria. Our review protocol was registered on the Open Science Framework in February of 2023. Our population involved children and adolescents from 0 to 18 years with a neurodisability, as defined by Morris and colleagues, and specifically those with a neurological condition who typically access tertiary hospital rehabilitation services. For the purpose of the scoping review, we defined neurodisability as neurological impairments resulting from specific acquired, degenerative and congenital health conditions, such as an acquired brain injury, cerebral palsy, spinal cord injury and other neurological disorders which may physically or psychologically impact a child or adolescent's functional capacity and well-being. We chose to purposefully include only conditions that typically access hospital rehabilitation services due to the limited evidence available and our interest to explore the role of music therapy in the tertiary hospital setting. Our concept was functional outcomes, which result from music therapy interventions in paediatric neurorehabilitation, as framed by the International Classification of Functioning, Disability and Health, Child and Youth version. The ICFCY framework assists in mapping the rehabilitation goals and outcomes of children and adolescents with neurodisability who experience a range of body function impairments. It is utilised by paediatric allied health professionals across the rehabilitation spectrum and provides a common language to support communication between professions and the development of common goals during interprofessional team planning. Our context included music therapy interventions delivered either in tertiary healthcare, including hospitals and residential rehabilitation, or community settings. We did not include studies that were not included by music therapists, but that did involve music therapy interventions. For example, some articles utilising neurologic music therapy techniques. We developed a search strategy and conducted online searches of databases and web pages to find primary peer-reviewed and grey literature sources of evidence of any study type and design. Our search of databases and other sources revealed 1,726 publications after duplicates were removed, and of those, 154 were considered eligible. After full text reading, reference screening, and expert knowledge user consultation, we determined that 71 primary and secondary evidence sources met the inclusion criteria. However, for credibility, we chose to only include 53 original primary sources for data extraction, which included peer-reviewed articles, dissertations, theses, and conference abstracts. Summative content analysis was used to extract and chart the data from the sources and was categorized under general, participant, and intervention characteristics, outcome measures, and functional outcomes. We found international representation of evidence spanning 40 years, with a range of source types and study designs, utilizing a range of outcome measures. 48 sources, including peer-reviewed articles and conference abstracts, were published in 27 different journals, almost half of which had impact factors ranging from 1.15 to 6.5. Our sources included a range of health conditions. The term neurological disorders was used as an umbrella term to include a range of conditions and where participant numbers were not clearly delineated for each condition. Our sources included children and adolescents with neurodisability across the spectrum of care. Of note was that 1/3 of sources detailed work with children and adolescents with an acquired brain injury in the subacute phase of recovery in hospital and residential rehabilitation settings. 75% of sources involved music therapy-specific interventions and 25% detailed interprofessional collaborations. We determined that music therapists use a wide range of methods and techniques, including movement to music, active music making, singing, songwriting, relaxation to music, and specific neurologic music therapy techniques. As mentioned, we utilised the ICFCY framework to map the outcomes of children and adolescents with a neurodisability. In this figure, you can see the number of sources that are reporting participant functional outcomes according to body function impairments, activity, participation, environmental, and personal ICFCY factors. All sources reported outcomes in the areas of body function impairments, which are presented on the next slide. Here you can see the number of sources which are reporting specific body function outcomes, with 27 or just over half of our sources reporting physical outcomes. This is followed by 25 sources reporting communication outcomes and 22 reporting social outcomes. You can find a further breakdown of these outcome categories in the scoping review article itself. And I should note that a number of the sources reported more than one area of body function. We found that music therapists use a variety of standardised and non-standardised assessments. as well as strategies, frameworks, and data collection methods. Information relating to the use and types of outcome measures is not detailed specifically in the review. However, relevant information can be found for each source in the online supplementary table, and the following slides will provide a summary of this. A range of standardised assessments were utilised across the sources. As you can see, no single measure features predominantly, and the range is indicative of the different age groups of the participants, the targeted area of function, assessments relative to specific conditions, and the potential of involvement of other health professionals in the study. The 10-metre walk test and the sit-to-stand test are the most utilised, and this is relative to the majority of sources reporting physical functional outcomes. Again, a range of data collection tools and types, strategies, and non-standardised outcome measures were utilised. Observation and record keeping was the most utilised tool, which is relative to the number of descriptive sources that were included. Qualitative tools such as questionnaire and interview also feature. It is interesting to note the use of the ICFCY and the TDM frameworks on which other tools for measuring or assessing individual functioning may be based. A range of qualitative and quantitative analysis methods were reported relative to the source designs. Quantitative statistics included sources such as abstracts that did not clearly define analysis techniques and other sources that utilized general quantitative analysis methods. Several sources reported using one or more analysis methods. More than half of the included sources were descriptive, and the term clinical reasoning was given to those that did not state or provide analysis methods. So while our review demonstrates that music therapy addresses a range of physiological and psychological functional outcomes for children and adolescents with neurodisability, more evidence is required across all health conditions and phases of the rehabilitation spectrum to assist with validity, interpretation, and generalizability. Most of our resources were descriptive, detailing how music therapy impacts function over time. Qualitative studies are important to assist with advancing person-centered care. However, further experiential and exploratory evidence is needed to demonstrate the causal effect of music therapy on function for children and adolescents with neurodisability, particularly in the acute and subacute phases of recovery. Replication and development of studies which explore the dose-response relationship is needed. Additionally, RCTs may be possible where sample sizes permit. Further research is required across all health conditions and levels of care. Acquired and traumatic brain injury was the most reported neurodisability in this review, with nearly all being completed in hospital or residential rehabilitation settings. However, most sources were descriptive. We know that the relative incidence of injury in the paediatric population impacts the sample sizes and heterogeneity, and this is a challenge for effectiveness studies in the acute hospital setting. For this reason, research in the subacute phase or later is perhaps better placed, and designs such as N of 1 or single-case experimental research designs and multi-site research collaborations and RCTs may be considered. Further knowledge regarding music therapy as a standalone or conjoined approach at different phases of care would be helpful to understand how music therapy supports patient goals as part of an interprofessional approach. To understand the distinct role that music therapy can play as part of pediatric neurorehabilitation, more research is required to determine the active ingredients that differentiate it from other disciplines across the spectrum of care. This could be achieved through use of conceptual frameworks, feasibility studies, and explanatory qualitative research. Additionally, studies which determine the utilisation and effectiveness of various music therapy techniques, including standardised neurologic music therapy techniques across all phases of the rehabilitation spectrum in paediatric hospital and community settings are needed. This may include feasibility and pilot studies. And lastly, Engaging the children and adolescents with neurodisability with whom we work and their families and staff in our research is essential. This will provide an understanding of the complexities and nuances of consumers' lived experience of music therapy as part of their neurorehabilitation, and it will assist in planning and shaping future healthcare and improving patient outcomes. We acknowledge that there are limitations to this scoping review, including the fact that the data extraction was completed by one person only due to the number of sources involved. We also acknowledge that during the process of completion and publication that a small number of new sources have been published, which is really exciting. We conclude that additional research is warranted to establish best practice for music therapy treatments for children and adolescents with neurodisability. I'd like to thank you for your time and your interest today. I've enjoyed sharing the results of this scoping review with you, and I'm happy to receive any feedback and questions at the email address here. And please access the full article and supplementary files via the QR code. Thanks very much. Bye.
Awareness that's used with adults with disorders of consciousness. So next slide, please. In thinking about assessment, I'm going to be touching on all of these points when talking about the research story of the MatterDoc. For me, I feel it's really important that assessment is based in clinical practice, but sometimes assessments are developed from theory instead. Both are really important. Both have strengths and weaknesses. So for assessments based in clinical practice, like the MatterDoc, it means that you can develop an assessment that's practical to you in your workplace. You can refine it over time, and you can really test it out with hundreds of patients or clients, because it's developed from clinical practice, and this can make it really sensitive and really practical. However, one of the drawbacks there is that possibly it may not be particularly theoretically driven. So there's some drawbacks and some benefits to developing an assessment from clinical practice. But some of the things to think about when you're developing an assessment, and most of us do this when we start a new job or start working with a new client group, what's the purpose of your assessment? So are you using an assessment to try and help you plan treatment, to identify strengths, to identify areas that need development? What's the purpose of your assessment? And to whom does the information need to be relevant? Is it for you as the music therapy clinician? Is it for the treatment team? Is it for the family? Is it for the client themselves? Because all of this helps you shape the way you develop an assessment. And something that I think is terribly important to think about, is it practical? I mean, do you need to have 14 one-hour sessions to develop to actually assess somebody? Because in most settings, that's not particularly practical. So thinking about how long it takes to assess, how many contacts do you need? These are all important parts for thinking about practicality. Let's move on to the next slide and get ready for kapow! Yes, 34 years. Okay, so we're going to start. Oh, I can't use my cursor. That's a pity. We're going to start. We're going to start in the, yes, if we could. Oh, I see. Okay, great. Can I take hold of that or not? No. No?
No, sorry, no. It's my slow call here.
That's fine. We're going to start with clinical development, top left-hand corner. So first of all, the MatterDoc grew out of clinical practice. It involved several different clinicians who had input into it, but I guess I was the one who ended up seeing it through. So over 14 years, it was just a local assessment. It wasn't even called the MatterDoc. I developed items, I withdrew items, I merged items. So during this clinical development stage, one of the things that we did, and this is particularly in the early days with Rosie Monaghan, was that we went to case reviews and we listened and looked at how the other professions talked about what they were doing with this very complex group, adults with profound brain injury and very complex disabilities. And it meant that we were modeling, without knowing it, we were modeling our developing assessment on another standardized assessment that had been developed at the hospital at that time called the SMART. So over 14 years, working with hundreds of patients, the items of the MatterDoc were really refined and very useful as a clinical practical tool. In 2005, I stepped away from working clinically, thank you. And during this 2-year period, Barb Davison took over the lead to refine it a little bit further for research. And then in the next box, Barb actually led on piloting the MatterDoc. And in this, we still didn't have the name, we were calling it the MATLIS at that stage, music therapy assessment tool for low awareness states, before the nomenclature changed. So at this stage, we were comparing the MatterDoc with other validated measures for disorders of consciousness. We had a look at how it stood up against the SMART, sensory modality assessment rehabilitation technique, and also the WHIM, the Wessex Head Injury Matrix. And those of you working in head injury, particularly in the UK, will be familiar with these tools. We did a little pilot there with just 9 patients, and it gave us a sense of what we needed to do differently when we were moving towards this bigger research study, which was always the goal. Even when I was working clinically, the goal was to start to really test the MatterDoc. Along the way, we did 2 small audits, not so small. Audits are when you look at data that's collected routinely as part of clinical routine data collection. So you're collecting the data as part of your regular clinical practice, and then you do a retrospective analysis of that data. Incredibly important way to examine and explore assessments and their uses, who they're used with, who they're useful with, what are some of the practicalities, the outcomes. So I really encourage you to think about how you might collect data routinely. One of those audits was by Barb Davison, and one of those was by Julian O'Kelly, comparing the SMART and the MatterDoc. Then we moved into this big study. This was the important study. So this is the top right-hand corner. That's it, the dark blue box. And this was the study where we looked at standardizing the MatterDoc. What you do with an assessment when you want to have a look at how rigorous it is you have a look at its reliability and its validity. Reliability is usually looking at its inter-rater reliability, meaning do two assessors, 2 therapists use it the same way? Do we come up with the same findings? And also we're interested in the test-retest. That is, do I use the assessment in the same way on different days or the same way with different patients? So reliability is a really important facet of assessments. Also, you might be wanting to look at its validity. And in particular, with this particular client group, where we're working with adults who we don't know whether they're aware of their environment, they're out of a coma, but we just don't know whether they're aware. We wanted to look at whether we were coming up with similar findings to other standardized assessments of awareness. So that was a study where we collected data with 21 patients. And indeed, we came up with very nice results showing that the MatterDoc had good inter-rater and test-retest reliability and excellent concurrent validity with the SMART. However, we published this in 2013. In 2010, there was a really important review of measures for disorders of consciousness published. It's like the most important review about disorders of consciousness measures. And that said that the only really valid measure for awareness in disorders of consciousness was the coma recovery scale and not the SMART. So here we were just finishing up data collection, looking at concurrent validity with the measure that was not the gold standard, or we're going to use the term here, criterion standard. That means the gold standard, the best measure for disorders of consciousness. So as soon as we were finished with this study, looking at standardizing the MatterDoc, we were already planning the study to examine its concurrent validity with the coma recovery scale. 2 small pilots were run on this, and these were led by Caitlin Bodine and Alika Su, who were based at Western Michigan University as part of their master's degrees, just with a very small sample, 8 patients. And that helped to give us some suggestions for how to research with a much bigger sample. And we're going to come down to the bottom right-hand corner. This is the study that's the biggest research study of my life, of my career. We collected data in a multi-site international study with 74 people with disorders of consciousness, with many collaborators. There were 13 on the research team. I can't name them all right now, but we were based in the UK. I was collecting data in the UK, Ireland, and the USA. And that's come out with a really important manuscript comparing how the MatterDoc sits with the coma recovery scale. And just to spoil the story, a bit of a story spoiler here, is that what's important with the MatterDoc is that it is a music-based measure. That is what is important, because with these patients with disorders of consciousness, the most sensory modality for determining awareness is the auditory modality, and yet the standardized measures such as the coma recovery scale are really insensitive assessments of auditory responsiveness. So that's where music therapy has a role, and the MatterDoc as a standardized measure has a role. So that's the story there. Let's come back up to the top right-hand corner, and then we're going to come down to the red arrows. And early on in the trainings with people, I hold trainings internationally. Nowadays they're online, so they're a bit more accessible. But what came out early on in training individuals was that they weren't working with adults with disorders of consciousness. They were working with children with disorders of consciousness, or people at end of life, or people with end-stage neurological illness, or people with delirium, or people, children, youth, and adults with profound and multiple learning difficulties, or developmental disabilities. End-stage dementia was another one. And so what emerged was that the MatterDoc may have a role in being useful for these populations. However, it had been standardized. It was valid for use with adults with disorders of consciousness. And so this opened up work to start developing it for new populations. And I'm going to just look at that end-stage dementia pilot work there. So in about 2017, I got some funding to do a small pilot with end-stage dementia to make recommendations for how the MatterDoc protocol and assessment might be developed to be standardized as being a rigorous measure for people, for music therapy with people with end-stage dementia. So that work, the pilot's been done. That work now hopefully is going to be taken forward by somebody else, so we can get a really good end-stage dementia measure there. And then we're going to come over to the big star shape, the pediatric pilot. So in 2013, 2015, in collaboration with Claire Getty, who's now based in Norway, but at the time was based in New York, we did a small pilot just for children and adolescents with disorders of consciousness, making recommendations for how the MatterDoc might be revised and adapted for children and youth. This work, moving into the next box along, was taken forward by Dr. Jonathan Poole, who worked over several years, who led on refining the MatterDoc, so that we changed the items somewhat and we changed the protocol a little bit, so that we could start testing out a whole new measure called the Musica, the Music Sensory Instrument for Cognition, Consciousness and Awareness. And Jonathan is leading on this international multi-center study where we're trying to collect data with 80 cases, and we're looking at the reliability of the Musica. How reliable is it between raters and test retest, intra-rater, and also we're having a look at how it compares to other outcomes of awareness for children. We're looking at the pediatric version of the coma recovery scale. So, and we've got other questions here. Do we need to have 4 sessions? Can we come up with a good diagnosis in just 1 session or just 2 sessions, which are really important, practical, pragmatic points. So that's very exciting. And then coming into that box to the right, Jonathan is committed to driving forward a sensory instrument, a really good sensitive sensory instrument that we can use with children and youth who have developmental challenges. And also, I'm still very interested in driving this forward. Maybe it can be the same assessment that we can use with people for end of life or people with delirium. So that's for the new populations, but then there's another whole strand going on, the validation in other languages, because although we had it validated in English, when you've got an English language measure, it's not necessarily valid from a linguistic point of view in other languages, or maybe the constructs don't hold as well. Is the construct of awareness relevant in different cultures, and can we measure awareness in the same way? So I'm going to say this very, very briefly. We've done some work looking at validating the matter doc in 3 different languages: Mandarin, Spanish, and Portuguese Brazilian. In brief, the work in Spanish and Portuguese Brazilian has just got to the stage where we're working with expert panels to really refine the linguistic accuracy, but also the cultural sensitivity. How should the protocol be adapted for those different cultures, and the different cultures within those language groups, which is more complex, to make it really sensitive to those cultures. With the Mandarin version, we've actually done a small scale tryout. So that was really interesting. How does it stand up as being culturally relevant within that culture? Again, China being many different cultures, but within the Chinese culture. And hopefully that work's going to be taken forward with a larger validation study in summer 2025. So just last slide, just to finish up. Sorry about bombarding you here with all that. Why is it important to use standardized measures in your clinical work every day? Because using standardized music therapy assessments optimizes the readiness for including your routinely collected data for the purposes of audit, research and development. And here are 2 examples. On the left-hand side, Rebecca O'Connor and Dee Gray from the National Rehabilitation Hospital in Dublin had their data included in a medical paper looking at the effects of zolpidem. Because they were using a standardized measure of awareness, they could just use their clinical data and be included in a research paper. On the right-hand side, there's a very nice example of protocol development from the team at Houston Methodist, where they, during the pandemic, they were on the front line of working with people who were ventilated in the ICU and were being weaned off ventilators, and they were having to assess whether or not these people were aware in any way or not. And they adapted the MatterDoc protocol, combining it with another protocol, and came up with a whole new protocol. So a very nice example of why using standardized protocols and assessments are important. And I think that's my last slide. So I'm just going to finish up by saying thank you very much. And I'm sorry that was such a whirlwind.
Thank you very much, Professor Magee. That was wonderful. And yes, so much work has been done and still to do on this area. So just looking, we have some time for questions, and these questions are for Dr. Waldon and Professor Magee, and I can also chime in if necessary. And of course, the questions for Karen Twyford, you can email to her, or we can have a go at thinking about that together here. So please type your questions into the question and answer section. I've got a few questions myself as well, but we have a question from Lisa L. Lakis. Hopefully I've pronounced that correctly. Apologies if I didn't. The question is, would it be appropriate to use a screening tool to develop a music therapy caseload prior to any assessment period? Thank you. Who would like to respond to that?
I say yes, it is appropriate. Again, it depends on what you're defining as a tool. I think that was the word, screening tool. I think, I don't know what your particular situation is, but music therapists often are working alone. They may have to staff an entire hospital, a facility. And so it's really helpful for the music therapist if you could clearly define what is the criteria for music therapy referral. And so talking about music therapy referral, what would you want to see in a referral, and having that as a checklist. I mean, that is an assessment tool alone. Not many people have written about referral in music therapy. I will say Dr. Suzanne Hanser has written in her book, New Music Therapist Handbook, she does outline some referral criteria, which I think could be helpful in developing a tool that you can use. It's kind of a screener, if you will, especially if it's important for you to identify those who may be in most need. And we want to avoid sometimes those referrals like, oh, this is a nice person, they like music. I mean, that's so very common. But really, I think this helps people that are making referrals make better referrals for you.
Yeah, Eric. Wendy, did you want to add anything to that?
Only that it's interesting. I note that the team at the Rehabilitation Hospital in Ireland do a screening. People are referred for the Matadoc, but they do a screening before the Matadoc. They do like a little mini, and I think it's because they want to get the assessment results as good as possible because there's so much wait. So I personally don't, I think you can just sort of start an assessment and moving into treatment during the assessment phase is very common with disorders of consciousness. But I think, yeah, sure, use a screening. Just something that's pragmatic. I think we need to be pragmatic, practical.
Yeah.
Okay, thank you. So, so Lisa, so there's your sort of answer to that. So yes, use some form of screening method, whether it be using a tool that someone else has put together or one that you might put together yourself for your own in your own practice. But it's generally a good idea, and that can help you manage the caseload and prioritize those most in need. So the next question is from an anonymous attendee. As a new music therapist, do you have recommendations for good ways to assess a wide variety of populations and needs? And the second question here is it a good idea to pull from various assessment tools?
Wendy, I went first last time, so.
Okay. I would say that when you're newly qualified, this is the time when it's really challenging. And I think it's a wonderful opportunity to get to know about lots of different clients' needs. So you'll get a sense of maybe that, people with stroke might have similar sorts of areas of need that you can address. So it might be that you identify domains, particular domains, behavioral domain, social communication domain, emotional domain, where you want to focus how they respond to music. And it might be that with children, you're focusing on very different domains, such as behavior and emotion and communication. So I think trying to look for patterns within your very diverse client group, and maybe you're going to focus on some particular behavioral domains more with that sort of broad category than with a different category. And stay focused on the music. Look at what is it that the music helps to bring out in people, and think about ways you can assess how people change within the music. I think that's the really important thing to think about trying to capture with any assessment. And again, remember, I don't know whether I said this, assessment is based in really excellent observation skills. It's a chance to build your observation skills.
Thank you. I would probably add to that as a new music therapist, you may feel the pressure of having to know everything all now, but actually, don't worry about that. You have a look at who presents to you in the sessions and think about what it is that you want to find out about them in order to be able to formulate a plan to help them. And that really is the purpose of the assessment at the beginning. What are their needs? How are they functioning? And how can you help them? In a nutshell. Obviously, there's more to it than that, but that's what I'd sort of focus on and try not to get too overwhelmed by trying to know everything right now. There are lots of resources online as well. You could go to the IMTAC website and you can find some resources there. And depending on the population you're working with, certainly if it's a mixed population as well, you might need to go to different sites like rehabilitation ones for acquired brain injury, etc. There's the Shirley Ryan Abilities Lab, which has about over 500 different types of assessment on there. They're non-musical ones generally. They're quite sort of generic ones, but you can go there. And then
Can I add something as well?
Children. Yeah, go for it.
Yeah. So one thing that Wendy pointed out, I think it's very important, is really focus on the domains of need that are related to your patient or your client. So one of the ways that I train music therapists, teach them, is make sure you have a referral reason first. Okay. And I always say something like a diagnosis is not a referral reason. So make sure there's a reason that the person has been referred to music therapy to address. There needs to be a specific referral reason. And then look at that referral reason and determine which clinical domains are really the most relevant to that. And um, and then draw assessment methods that are going to help you assess that particular that domain. So usually we start with a referral reason, we identify domains, and then I have people make a list of what are some questions that I want to have answered through the initial assessment process. And once you come up with the stuff that you need to know, then you can figure out, well, is there a tool that I can use to address that? Or, can I get this through an interview? Or would this be somewhere in the records? So, so I think it all starts with a referral reason. Again, this really talks about, a way to assess a wide variety of populations. Start with a referral reason. And I think as soon as you start determining which domains are the most relevant, then if you're going to use assessment tools, named instruments, then they're going to kind of coalesce, around those particular needs. You're going to find like, oh, these are the tools to use to assess, whatever particular need. And so your last question, last part of your question there is it a good idea to pull from various assessment tools? Yes, it is. I think there's sometimes an idea in music therapy that, you're a music therapist, you have a philosophy from which you practice, and therefore there's only one tool that you can use. And there is no tool out there that, this is the one that you use for all situations. Psychologists, we don't work that way. We have a variety of tools that we would use for different reasons, different needs, depending on the referral. So.
Wonderful. Thank you. Right. We're slightly over time. There aren't any more questions. And so I think we'll need to wrap up, if that's okay with you two, unless either of you have any questions for each other. No.
I've got endless questions for Eric, but really we'd be here until midnight in Australia time. So
That's right.
Okay. All right. Well, I'd just like to thank, I'd like you to all join me in thanking Dr. Eric Waldon and Professor Wendy Magee, and of course Karen Twyford, for their wonderful presentations and this discussion. Thank you both, all three of you, in fact.
Thank you all.
Okay. Thank you all for attending, and wish you all well. And whatever time it is, your time zone, have a wonderful day, morning, night.